Good afternoon or good evening or good morning for all of you that are joining this webinar on gut and immune health in food allergy. My name is Roseanne Meyer. I'm a pediatric dietitian who works especially in food allergy. This is a live and interactive webinar, and I'm going that is supported by Nutricia. Now, today's webinars on gut and immune health, the safety and added value of pre and synbiotics in the nutrition of allergic infants. I agree that this is an amazing topic and also a very exciting topic that has had a lot of research over the last couple of years. And therefore, it's my pleasure to start introducing our two speakers. I'm sure these are names that you've heard of. The first speaker is going to be Professor Udo Herz. He's Global Industry Medical Science Director for Danone Nutricia, and he's going to talk about gut health, pre and synbiotics in the management of cow's milk allergy. Whilst he's talking, please send our questions too. And then I'm going to come up again, but I already want to introduce our second, a very eminent speaker. I think all of you've read papers from Professor Seppo Salminen, who's the president of the International Society of Probiotics and Prebiotics. And that webinar session will be in the form of an interview between Professor Udo Herz and Professor Seppo Salminen, but you'll have some slides as background.
Thanks a lot for the kind introduction, and it is a great pleasure for me to talk today about gut health and the role and the potential role of pre and synbiotics in the dietary management of cow's milk allergy. Before starting actually with the presentation, I like to declare the following. I'm a full-time employee of Danone Nutricia Specialized Nutrition. I'm a professor at the University in Marburg in Germany on immunology and laboratory medicine. And I also be the president-elect of the European Federation of Specialized Nutrition Europe, which is the umbrella organization of the European dietetic food industry located in Brussels. So let me start with cow's milk allergy. Cow's milk allergy is a multi-system organ disease, and we know it affects the gut, the skin, the lung, and it has also a systemic component in its reaction of anaphylaxis. And all these disease symptoms have their own timing, acute, delayed, immediate, chronic, but they also have their own pathophysiology. So GI manifestations are very different from skin manifestations, and sometimes they overlap. But as different these disease manifestations are, as similar is the root cause. Actually, the root cause of these diseases is a dysregulation of the immune system. They have all this in common. And that is very simple. It is actually a complete black and white situation. The immune system either reacts towards an antigen, an allergen, if it recognizes it as harmful. That is what the immune system should do. It reacts against pathogens, and it reacts sometimes unnecessarily to normal food allergens. So the pattern is it recognizes it as harmful. Simply the opposite, a healthy state is recognizing, so an active process of the immune system as a food allergen, harmless. And that is called oral tolerance, and it is a maintenance of a non-responsiveness state. And there is nothing in between that. So there is nothing like a little allergy. It might be the severity and the symptomatic might be different from low severe to high severity, but the immune system either recognizes something as harmless or as harmful. And the break of tolerance and the acquisition of tolerance is a state which is very hard to achieve, and you all know about how difficult it is to achieve back acquisition of tolerance with specific immune therapy, actually we are desensitizing more the immune system than actually providing real state of oral tolerance. So if I want to go very high level in the regulation of the immune system needs two signals to mount an immune response, either to harm or to harm less. And the first signal is the allergen. Without allergen exposure, there is no allergy. That is the principle of our dietary management. But whether the immune system reacts or develops a memory function towards an allergen depends on a second signal, which is provided by the environment, but is also triggered by the interaction of the gut microbiota. So if we look then in the principles of the dietary management of cow's milk allergy, it is strict allergen avoidance. We use this principle of strict allergen avoidance for diagnostic, but also for management. And if you look on this slide, there's a summary of the most products which are on the market. On the left side, extensive hydrolyzed formulas. On the right side, amino acids. They have all fulfill the category of being hyperallergenic, being useful to manage the dietary management of cow's milk allergy, meaning to have a strict allergen avoidance. Nevertheless, these products have significant differences beyond the source of the protein and the degree of hydrolysis or the use of amino acids. So it's not only about the strict allergen avoidance. These product needs also to fulfill nutritional requirements, and in some situations they are the sole source of nutrition. If we look a little bit more deeper in how different hyperallergenic formulas are in their composition, there are huge differences. I have listed here energy, protein, fats, carbohydrates, micronutrients, nucleotides, prebiotics and probiotics. So as an example, only 15% of the formulation have in the fat content alpha-linoleic acid in similar amounts than human milk. So they differ quite significantly from human milk. Also, only 77% have nucleotides. And if you look into the ingredients which are actually supportive of gut microbiota, which are supportive of immune stimulation, in terms of prebiotics, only 15% include carbohydrates, GOS-FOS, and only 8% include probiotics. So the differences in the formulation with the additional and optional ingredients is enormous, beyond the hydrolysis degree and beyond the amino acid composition. Why is this important? It is important because 70% of all immune cells are organized in the gut-associated lymphoid tissue. And we also know immune maturation depends on the gut microbiota signals. There's a close interaction on the subcausal level between immune cells and their maturation, their rolling, their adhesion, their signaling with commensal bacteria. And the gut colonizes actually after birth, some say even before birth, but the major effect in colonization, especially with bifidogenic effect, the bifidogenic effect immediately after birth, happens within the first months of life. And that is exactly where the immune system needs stimulation, needs maturation, needs exposure with the environment to develop full functionality. Our picture on cow's milk allergy and how important the gut and the interaction with the gut microbiota is has been triggered quite significantly in the past years. And I like to show you as an example how important in our today's view the gut microbiota biota in food sensitization and cow's milk allergy is on two examples. The first example is we observe that dysbiosis in infant gut microbiota precedes food sensitization. And the risk factor for dysbiosis could be, as an example, cesarean section. There's a huge difference between vaginal-born infants and cesarean-born infants. And Assad and co-authors looked actually in a prospective trial and compared the microbiota at 3 months and at 1 year in infants who did not develop a food sensitization and infants which developed a food sensitization. And you see this is a very high-level picture, but you see on the dark blue bars and on the brighter blue bars, there's a huge difference in bifidobacteria and Firmicutes between non-sensitized and sensitized infants. Actually, one could conclude that a lower gut microbial richness at age already of 3 months is associated with an increased likelihood of food sensitization by 1 year of age. But it is also gut microbiota not only important for developing food sensitization, it is part of the solution. The long-term resolution from cow's milk allergy is actually associated with a higher gut microbiota diversity. And again, it is the same principle. It is the taxa with Clostridia and Firmicutes are enriched in samples of infants at 3 to 6 months, which had a milk allergy resolution compared to the persistence at age of 8 years. And also we could even dive in a little bit deeper that the fatty acid metabolism is significantly associated with this resolution. So in conclusion of these two slides, one could say the gut microbiota is important for the onset of food sensitization, but also for the resolution of food sensitization. And that has triggered actually a new paradigm shift in the management of cow's milk allergy. Over decades, and this is still true, avoidance, strict allergen avoidance is the key principle to not activate the immune system to develop a hypersensitivity reaction. But in terms of management and in terms of active management, this paradigm shift goes now and includes the gut microbiota with a specific stimulation with pre and probiotics as part of the solution. So if we look into what are prebiotics and probiotics and what is symbiotics, it is very simple. We have quite definitions published even by the FAO, by the ISEP guidelines and so on. But in principle, prebiotics are non-digestible carbohydrates, non-digestible for the human carbohydrates, but they are digestible for bacteria, for the gut bacteria. So you could maybe say, easy, prebiotics is the lunchbox to stimulate the growth and activity of gut microbiota. And one example is the short chain GOS and the long chain FOS. And probiotics, live bacteria, active bacteria, have been selected and chosen for specific beneficial effects. Actually, the concept of probiotics is now already more than 100 years old, and we have a lot of probiotic strain identified. The example I here use is the Bifido Breve M16V strain, so a Bifido strain which also naturally occurs in human milk. So if you put those two together, you get symbiotics. You get the lunchbox for alive and Activia bacteria to stimulate gut flora and the immune system. Let me a little bit elaborate on where prebiotics actually were coming from. Human milk is rich of prebiotics. Actually, it is a significantly third biggest fraction in human milk. And the key principle there of human milk oligosaccharides is actually the diversity. From their structural, compositional possibilities, more than 1,000 structures are possible. At the moment, we have identified 162. If you look in the lower part of the graph, you see there a mass spectrum of the different sizes, the different lengths, the different molecular weight of human milk oligosaccharides. And next to that, you see actually short chain GOS and long chain FOS in a 9:1 ratio, mimicking 100 different structures in lengths and in molecular weight, almost or close to human milk oligosaccharides. So the principle of mimicking and adding prebiotics like GOS and FOS into infant formula is actually to try to mimic the diversity and functionality of human milk oligosaccharides. If you look then, does it really work? These are old studies and it is well studied. There's more than 30 clinical trials performed with this mixture. But the key effect is actually the stimulation of the so-called bifidobacteria, the good bacteria. And if you look at the right side of the graph, you see there an extensive hydrolyzed formula versus an extensive hydrolyzed formula containing GOS-FOS, and you see an increase in bifidobacteria and you see an increase in lactobacillus close to what we see in breastfed infants. And another effect, which is very well documented and has been shown in 6 clinical trials, is the softening, the stool softening effect of these prebiotics comparable to breastfed infants. So if you allow me to look a little bit more specific in the probiotic, in the bifidobacteria from Bifidobreve M16V, why we have chosen this bacteria. So first of all, B. breve is a natural species in the infant gut. And second, breast milk contains actually considerable amounts of B. breve. And third, it is the most commonly isolated strain from human milk. And fourth, the long history of safe use. I will go in there in a little bit more deeper. And also that Bifidobreve M16V early establish a normal intestinal microbiota and is in fact effective in the prevention of infections in preterm infants. So adding of probiotics into infant formula, especially in infant formula, which is used for the dietary management of cow's milk allergy, needs a special safety consideration, because some of these infants have also a disruption of their gut barrier function. So it is extremely important to have a well-documented safety profile of probiotics used in this disease condition. And I listed here 12 clinical trials on the safe use of Bifidobreve M16V in infants with disease, in infants with actually extremely immature gut barrier, extremely premature infants, but also with neonates in intensive care unit, and also obviously in healthy term infants. So if you look these data together, it is actually a substantial track record of safe use in infants and in infants with disease. So let me continue and show you some results about the clinical efficacy. In totality, we have performed 6 clinical studies assessing the safety but also the efficacy of symbiotics in the dietary management of cosmic allergy. And you see there, 2 studies have been performed with extensive hydrolyzed formula, the 2 upper one in this table, and 4 studies actually with the amino acid formula. In totality, all these 6 clinical trials have assessed more than 700 infants in terms of growth, in terms of safety, but also in terms of efficacy of this specific products and of this specific combination. Let me break that a little bit down. 3 randomized controlled trials have actually demonstrated the hyperallergenicity of this formula, the safe and well use of these products in terms of growth and safety in cosmic allergic infants. These have been assessed over the first couple of months in healthy infants, but also in infants with cosmic allergy. Let me continue on the principle of they need to be effective in the resolution of the symptoms, but also being effective in stimulating the gut microbiota. And in this table, it is the summary of 3 randomized controlled trials that demonstrate that symbiotics are actually able to rebalance the gut microbiota of infants with cosmic allergy and bringing them a little bit closer to that what we actually say it's a healthy gut colonization, it is a healthy breastfed infants. And you see there it's infants with cosmic allergy, but also subdivided in infants with cosmic allergy which have a non-IgE mediated symptomatic, but also an IgE mediated symptomatic. And in all of those conditions, we actually observe a rebalancing of the gut microbiota closer to human milk-fed infants and closer to a higher diversity. If you then look in subgroup analysis, what is actually the effect of symbiotics beyond the resolution of the symptoms, beyond the adjustment of the gut microbiota and increasing the diversity? We see also other effects which are actually indicating that there is a positive impact on the immune system. And you see here, it is the reduced prevalence of infections, the reduced use of antibiotics, which is a proxy for infections, but also you see fewer ear infections and the use of anti-infectiveness and days in hospitalization. So all indicating that this combination together with the hyperallergenicity has actually a positive effect on the immune system. So if you summarize all these 6 clinical trials and you look at the manifestations around infections, the manifestations at the gastrointestinal tract, skin and manifestations, but also manifestations at the lung, you all see lower prevalence, lower incidence, and lower use of antibiotic or medication in these disease conditions. So let me summarize at the end the key messages. I think we are entering a new turning point in the management of cosmic allergy. There is a shift in this paradigm from avoidance only to an active management, which includes other parts of the immune system, which includes the microbiota, which includes nutritional component, and what might include in the future other concepts like the concept of tolerogenic peptides. we know that the gut microbiota dysbiosis is part of becoming allergic, but it is also part of the solution in the management of cosmic allergy to acquire tolerance, but also to overcome maybe in a faster way the symptoms and get and maintain symptoms resolution. So the addition of synbiotics is actually offering a new treatment option. And we believe, and I think we can show, and we have demonstrated in our clinical studies, that this specific blend of GOS-FOS or FOS-FOS and B-Breve M16V helps to restore the gut microbiota and to support long-term health and immunity compared to allergen avoidance alone. With that, I thank you for your attention.
Thank you very much, Professor Hertz. I'm sure you can agree that was a fantastic introduction to this topic. What we're going to do next, now we're going to move into the next topic, which is biotics from science to clinical application. Where are we? And that's in the form of a really lively Q&A session between Professor Salminen and Professor Udo Hertz. And we're going to switch over to that now.
Thank you very much. It is a great pleasure for me to take you to the next session, which is an interactive discussion with Professor Seppo Salminen, entitled Biotics from Science to Clinical Application, where we are. It is a great pleasure for me to introduce Professor Seppo Salminen. He is not only an expert in food science and in nutrition, in food chemistry, he's also an expert worldwide recognized in different expert panels. As an example, since the establishment of the European Food Safety Authorities, he was 9 years a permanent member of the panel of nutrition of novel food, assessing the efficacy and the safety of nutritional components in food. But he's also a professor not only in Turku, in Finland, where he's based, but he's also a professor in Vienna, in Austria, and in Australia in the topics of food safety. So it's for me a great pleasure to have such an expert here to run through a couple of questions around biotics, around prebiotics, around probiotics, and around synbiotics. So I'd like to introduce you a little bit what we are planning to do in the next 15 minutes. We like to bring you some insights and clarity on what actually prebiotics, probiotics, and synbiotics, what they are doing, how their safety is assessed, where the opportunities is for the dietary management of cosmic allergy, and where we have new opportunities to come in the next years. So thank you very much for me, and great pleasure to join me, Seppo. Let me ask you bluntly, with all these biotics, prebiotics, probiotics, postbiotics, synbiotics, I'm completely lost. Can you give me some simple explanation what they are actually?
Dear Udo, first of all, the pleasure is mine to join in this discussion. It's important that we characterize the biotics family. When I started my career, we only had probiotics. Probiotics, live microorganisms that, when administered in adequate amounts, confer a health benefit to the host. Then a little bit later, the idea of prebiotics was introduced. Prebiotics substrates for beneficial bacteria, either in the food or in the gastrointestinal tract, that are conferring a health benefit when prebiotics are administered. And then a little later again, we also found that we can combine probiotics and prebiotics. And that defines the word of synbiotics, combination of beneficial bacteria and substrates for the beneficial bacteria. And most recently, the very most recent idea is the postbiotic, even though not a target for today's session and discussion. Postbiotics are still emerging. They are bioactive components produced by microorganisms in food fermentation processes, where the microbes at the end are inactivated. So inactivated microbial cells and their metabolites. And all these are actually classified in a consensus document on probiotics. The first one, Nature reviews in gastroenterology and hepatology, then prebiotics a little bit later. Synbiotics are just in press, the consensus definition, and postbiotic consensus definition has been submitted to Nature reviews. So there are open access documents to actually look at the science behind all these biotics. And I think the postbiotic part completes the biotic family. So maybe it's a little bit confusing, but when you take a careful look, you have the live bacteria, the substrates, the combinations, and the bacterial metabolites.
So all these concepts are actually built around gut microbiota development to support somehow a microbiota colonization. Can you tell me something around why the infant gut, the early colonization, is so important? What is so special around that?
Well, let me first focus on probiotics and prebiotics. Prebiotics are, for instance, human milk oligosaccharides, or the GOS-FOS oligosaccharides as used in Europe. Probiotics are mostly in infant area, either lactobacilli or bifidobacteria, and the combinations then come out as synbiotics. If we think about the gut colonization, what is the role of these components? Of course, for a long time we thought that gut colonization starts at birth, but now we know that microbial exposure takes place already before birth. So probiotics, prebiotics, synbiotics, they are most important not only to the infant but also to the mother to create the nice, natural, beneficial environment in the microbiota in the pregnant mother and later on in the newborn. Of course, after delivery, we have a rapid accumulation of bacteria in the gut, most of them actually coming from breast milk, but also some of them from environment. And the most important part today seems to be the predominance of bifidobacteria in a healthy developing newborn gut microbiota. Also, lactobacilli, they play a role, and their interaction actually controls the integrity of the intestinal epithelial wall and the integrity of the gut microbiota. And this, of course, is important not only during infancy, but also during childhood. The gut microbiota in a healthy state protects us from environmental exposures. And later on in adult life, and especially in the elderly, we again have a very similar situation, predominance of bifidobacteria and lactobacilli in the healthy gut microbiota.
Is there something like a healthy gut, especially in infants?
It is a challenge to define what is a healthy gut, but basically we have developed guidelines on looking at probiotics, prebiotics, and synbiotics and their role in gut microbiota development by the International Scientific Association of Probiotics and Prebiotics. There are guidelines for the consumers, which are very simple, and there are guidelines for clinicians, which go deeper into the idea of what is a healthy gut, how do probiotics and prebiotics improve the gut microbiota, and what are the consequences of dysbiosis if it's not corrected by some external administration of these novel components.
So especially for the cow's milk allergic infant, there's a lot of discussion ongoing around dysbiosis and setting and pre-setting either the development, but also in terms of the resolution. So the first recommendation actually for a cow's milk allergic infant is still continue breastfeeding. So what is so special around this concept if you compare it to human milk?
Well, the concept is actually mimicking what is happening in human milk. This is my favorite slide for presenting the background for this information. So if we think about the dysbiosis in cow's milk allergic infants and breastfeeding, we also have the probiotic type of bacteria in breast milk. They help to balance the intestinal epithelium, preserve intestinal integrity, and in the same way, prebiotics, the human milk oligosaccharides, or the GOS-FOS oligosaccharides, they help to promote the bifidobacterial growth, lactobacillus growth, and they provide a symbiotic environment. And of course, we also have to remember that there are some postbiotics, some inactivated bacteria, and their metabolites in breast milk. So all this combination is actually most important when there is a state of dysbiosis, as there often is in terms of cow milk allergy.
So let me maybe challenging ask you. So human milk seems to be a perfect combination of all of that. But sometimes in infant nutrition and in products for the dietary management of cow's milk allergy, you find either a product which contains prebiotics or human milk oligosaccharides, and you find a product which only contains probiotics. So do I need them all?
I think basically, if we think about the healthy gut microbiota development, human milk has all of these. It has probiotic type bacteria, prebiotic type components, and they work as symbiotics together. So I would say that the more diverse composition you can create, the closer to human milk it appears to be at the end. So in those terms, I would say yes, you need all of them.
So we are actually in an exciting times. So science is accumulating, and we have a lot of papers and also quite some insights into the advantages of dietary management of cow's milk allergy with these biotics. But it seems it has not reached guidelines. It has not reached into actually expert committees. Why is that? Well,
I would actually say that when we think about, for instance, probiotics, the clinical intervention studies have been done for the last 30, 40 years already, and probiotics have not received any health claims for infants in Europe because there has been insufficient evidence, mainly on studies in human adults. Most of the studies reported until now are with adults, and only a minor part is in infants. However, we do have recommendations from medical and nutritional societies, although we don't have any health claims. And this actually describes the situation of science being in the forerunner and regulations always coming a little bit later. It takes a long time to change the regulations, but recommendations are there. And actually we have recommendations from the European Society of Pediatric Gastroenterology and Nutrition with probiotics and prebiotics. The World Allergy Organization has published recommendations on probiotics and prebiotics. And most recently, the American Gastroenterology Association, just a couple of weeks ago, had their recommendations on probiotics and prebiotics. So yes, the science is faster than the regulation, but we are having really nice results that confer that there are benefits for probiotics and prebiotics and symbiotics. So I would say that yes, there is a way forward also in infant nutrition and also in cow milk allergy.
So before any benefit and recommendation, safety comes always first. So let me ask you a couple of questions around safety, and especially safety of the use of Bifidobreve strains in a gut disturbed situation. The cow's milk allergic infant has a gut disturbance. So how is actually safety assessed in those cases?
Well, you brought up the Bifidobacterium breve. I would probably put it in line with the general safety assessment procedures. And first of all, if we think about European Union, we have the EFSA qualitative presumption of safety QPS list, with on the species level describe the safety of microbes added to food, including infant foods. And Bifidobacteria, lactobacilli, most of the species are there, including Bifidobacterium breve. And this actually is based on long-term experience on safety, long history of safe use of the species, all the information that has been published on the safety of the species, and at the same time, it's progressively re-evaluating the safety status annually, publishing biannually the QPS list updates. And that, to me, is one of the best safety documentation procedures in the world at the moment. If it was up to me, I would recommend it also outside Europe. A completely different, but also quite critical test assessment system is in the United States. If we look at the so-called GRAS substances, generally recognized as safe substances, we do have there both Bifidobacterium breve, as you mentioned. It is on the GRAS notification list for infant formula for infant use. And there are some other probiotics and prebiotics that have been assessed the American way, using an independent expert panel which submitted their report to the US Food and Drug Administration. So these two safety assessment systems are actually, to me, a guarantee of the safety of a particular strain and a particular species. And of course, if we go on the strain basis, then we should look at the clinical data. We should look at clinical data in intervention studies, in infants with cow milk allergy, preterm infants, and either do comprehensive analysis or meta-analysis, comprehensive reviews on the safety. And again, most of the currently used probiotics and prebiotics are safe. And with some of them, we do have 30, 40 years clinical experience, 20, 30 years clinical follow-up data. And based on that, again, meta-analysis on the information. This, in addition to the traditional safety data of impact on growth and development, things like antibiotic resistance, which should not be present and should not be transferable, all those factors together guarantee the safety of a particular strain.
So let me close with a short question at the end. Where are we going? Where's the crystal ball? More strains, more oligosaccharides, more of everything?
Oh, I wish I had the crystal ball. But if I take just purely the scientific approach to this, I think when we look at human milk, again, as before, it should be used as a model, and it tells us that we need to look more, we need to study more the human milk oligosaccharides. There are more than 200 of them, and we don't know exactly how important some of them are. We also have to assess the gut microbiota composition better. But while we wait for these developments, I think we should make use of the most up-to-date safety and efficacy information that we have for each particular use. And that actually combined together with the search for new things for the future gives us a fairly good standing today on the safety and efficacy of the products available today.
It was a great pleasure. Thanks a lot, Seppo. It was a fantastic session. And with that, I'd like to close. Thank you.
Thank you.
I think all of you will agree that this was an amazing session, and I want to really thank Professor Udo Hertz and also Professor Seppo Salminen for really making this webinar so alive. Both of you, you'll be happy to know we've got plenty of questions, a nice diversity of questions. I'm going to start with you, Professor Salminen, with a very nice introductory question on what you think the difference is between symbiosis and dysbiosis.
Oh, goodness me. This is a very nice question. Symbiosis, I think to me it means that living together. And in terms of microbiota, that's what we are doing every day. We live together with our microbiota. It's and in many ways, if everything is right, it's a good cooperative relationship between the microbiota population and ourselves. It keeps us healthy and we work together.
And what about dysbiosis?
Dysbiosis to me actually means a microbial imbalance. So there's something wrong with the microbiota composition and or activity of the microbes. And of course, if we think about it from a very personal basis, then signs and symptoms of dysbiosis are digestive disturbances in general. So people may feel gas or bloating or have other abdominal cramping, at times even diarrhea. So clear indications of dysbiosis.
And I'm going to ask the same question. Do you have anything to add, Professor Hertz, to that question? Because I'm sure you like that question.
Yes, I like to pick up what Seppo said, working together. That is the principle, working together and achieving a better result as staying on its own. So that is the symbiotic concept. 1 + 1 is more than 2. We see that in nature when animals are working together. We see that in our gut every day, and the same is true what we see in dietary management of allergy.
So I'm going to press you both because so what is dysbiosis? What is normal? Can we actually establish that? I'm going to start with Professor Hertz because he had a smile on his face, so I'm sure he's ready to answer that first.
I need to say I'm not a microbiologist. Yeah? For me, normal almost does not exist. What is normal? I think what is normal, what I have. That's normal for me. It's my personalized experiences. It's my personalized gut microbiota. That is what is normal and what is healthy. If I'm getting ill, then it's not anymore normal. So I need to reestablish what is good for me, where I was starting. And in terms of infants, I think dysbiosis, how we define it is, I like this cesarean section example. A vaginal born infant has a complete normal given by his or her mother colonization first, and not the one which is in the hospital.
Yeah. So Professor Salminen, what is your opinion? What is normal or what is abnormal? Can we establish that?
Normal is very, very, very special. It's very personal, as Udo was telling earlier. But even the normal is not the stable thing. It's something that fluctuates within the certain frame every day. We do have a framework which indicates what is normal to our personal selves. And if I think about it in terms of infant, normal to me would be the gut microbiota of a healthy breastfed infant who stays healthy for a long time in the future.
That's a great answer. And of course, it leads to a question that I would have totally agreed with asking. And it's something that we see in our clinical practice often. And the question actually says, is it therefore worthwhile for a baby to go and say, okay, I'm having my microbiome tested? And if you say yes, this person also says, what test would you use? So I'm going to start with Professor Salminen.
Well, this is a real challenging question. The microbiota testing has developed. It has developed a great deal in the last few years, but we still don't have a standard test that would give you an answer of the question of what is normal and what is personal. However, there are some tests where you can test where you can see, for instance, the pathogens, the perhaps excessive levels of bad microbes, but nothing that I could recommend yet.
Yeah, because as a clinician, I find it very difficult. I often have parents that come with the tests and they say, now go normalize my baby's gut. And I really struggle to know what, as a clinician, I can do.
I think you are well off if you have a test that indicates that there are some bad bacteria or some pathogens, and then you can go ahead and recommend something to treat the condition. But an outright test that would say that no, this is normal and
Or
this is
abnormal
doesn't exist yet.
Yeah. So, Professor Hertz, I've got a really nice question for you, because you touched on extensively hydrolyzed formula and amino acid formula, and I think it's an easy one for you to answer. But the question actually said, would you consider an infant that has been only on an extensively hydrolyzed formula or an amino acid formula, would you say that their gut is sterile as a result of being on these formulas?
No. Because bacteria live on many things, and also a cow's-milk allergic infant has a gut microbiota colonization. Whether it's less diverse or rich in diversity is a different question. But we are not killing, or we are not providing enough in nutrition that the gut microbiota can survive. The different question is. The dietary management of cow's milk allergy is built on nutritious and suitable and adequate nutrition for the infant. But that should also include nutrition and adequate food for the bacteria. Yeah. That should come together. I like that what Seppo said, working together. Working together is the body. It's not only the body, it is also what happens in the body.
Yeah. And of course, the microbiome is not just driven by what we consume, but as soon as a baby's born and everything else is affected. So I have quite a complex question here, and I think it's a nice interplay. I'm going to start with Professor Hertz here again, and then move over to Professor Salminen here. And the question, if I directly read it, is the vicious cycle between cow's milk allergy and the normal gut microbiota. So can cow's milk allergy actually create a hostile gut environment, and therefore have inflammation within the gut, and the microbiota or the dysbiosis therefore exacerbate this situation? So it's a complex question, in fact.
It is really an interesting question, and I think there will be not an easy answer to that. And actually, I think it is a cycle. There is inflammation, then you get something which disturbs the gut microbiota, and then it gets up and down. Actually, it fits very nicely in this chronic versus acute symptomatic, and we see those types of gut microbiota disturbance also in other diseases, much more severe. If you think about Crohn as an example, where the reaction is also an autoimmune reaction against the own bacteria, at least in part of the disease. So you see, this crosstalk is not only in good, it is also in bad.
And Professor Salminen, what do you think around this kind of cycle that you can get in, almost an inflammatory cycle where one makes the other one worse?
It's a very interesting cycle. The challenge there is to know what is the cause and the effect. Yeah. And if we think about it, the gut microbiota has a major role there. If we do correct microbiota imbalances by probiotics or prebiotics or symbiotics, then you can actually reduce the symptoms. So I think it also comes back to what is normal, what is personal, and reminds me of the fact what you asked earlier, that gut microbiota is always there. The infant gut microbiome, gastrointestinal tract is never sterile. Yeah. So it needs to be colonized with the friendly and healthy bacteria.
Yeah. So if we're moving on, I'm going to now move into some of the very practical questions here. And I think, Professor Salminen, this is a really good question for you, is that there was one of the respondents that asked and saying, a baby has lots of different types of bifidobacteria, for example. So why are we saying just here, for example, just the Bifido as a strain? Why are we, in general, why are we just having specific strains that we are recommending and not a whole mix of strains?
I think it's based on the knowledge of today. If we know we have tested strains that are safe and effective, and if we start adding other strains, we need to do more complex studies again. It's most likely that in the future there will be a diversity of strains, but it's a long way forward before you can take them into practical use. Yeah. So I think having a safe strain and an effective strain and perhaps some prebiotic components to that is the best way to start.
Yeah, and Professor Hertz, what would you say to that question? Why are we so strain specific? Why have we talked today about Bifido breve, for example?
First of all, we are at a starting point, and it is strain specific. Every effect is strain specific, but there's also something what we learned. Putting together two strains might have a complete opposite effect. We know that from in vitro experiments and from animal experiments. So just simply the idea, I take two good strains or 3 or 4 or whatever, does not work. They interact to each other and they can actually create an adverse reaction. Yeah. So it is not only more, adding more is better, more is good. It is actually, again, very selective, and every combination needs to be assessed individually.
And that's why for me, the concept of symbiotics, working together, actually works really well, because it actually really helps from from that perspective. So we also have here questions, and I think that's an important question. It's not only about the strains, but about the quantity. And then I think I'm going to open it up. I'm not just going to say, for example, Bifido breve, what is the exact quantity? But if you want to have a clinical effect, Professor Salminen, what is the quantity that you actually need?
The quantity is also very, very strain specific, even species specific. And if we think about what has been used until now, it also depends on the target. If you are working on food allergy, or if you are working on diarrhea, perhaps prevention of diarrhea, the specific strains, the specific products have all their own dosage level. And it's even defined in the definition of probiotic that you need to have a level that has been tested. For instance, in diarrhea prevention, it's quite often 10 to the power of 8 bacteria per day.
And Professor Hertz, have you got anything to add to that?
Yeah, clearly there is a dose-dependent effect, but what I also like to point out in terms of dosing is it's a daily consumption. Over weeks, sometimes over months. And what you want at the end to see is the moment you stop, the strain disappears. You don't want to have a permanent colonization. That also is on a daily consumption an important factor. It's not only the one shot, what you take as a pill. In infant nutrition, you need to think about that this is over weeks and months, and so a low dose exposure, if it is sufficient to achieve the beneficial effect, don't increase it.
And therefore, I think a question that really leads nicely into this is whether overuse of
Mhm.
probiotics can lead to small intestinal bacterial overgrowth.
Mhm.
So, Professor Hertz, do you want to start on that one? I mean, I think it's a valid question.
It's a very valid question, but I think at the moment what we are seeing in daily or what is used in infant formula is doses between 10 to the 4 to up to 10 to the 12 per day. That is still at the lower end of a scale. If you think about an adult has more or less 1.5 kilogram of bacteria in it. I don't have the number for infants, but we are talking here also about gram, hundred of gram of bacteria. So overgrow, I cannot foresee that with that doses we have at the moment.
Yeah, and Professor Salmonen, anything you want to add to that question?
I would very much agree with that, and we have to think about the volume of formula that's taken, or if you consider breast milk volume that's taken. It's of course dependent on the age and size of the infant, but the concentrations of the added probiotics are so low compared to the other bacteria present in the infant gut that they are really nurturing the gut rather than causing any overgrowth.
Okay. So I'm going to move to, we had lots of questions on whether pre, pro, and symbiotics are the answer now to everything from prevention to tolerance induction. So I'm going to split it up. I'm going to say, and I'm going to start with you, Professor Hertz. Do you think, if we're talking about first prevention, do you think pre, pro, symbiotics, and you can specify what you think better, do you think we've come to a point where we can say, actually, this is most probably going to be the answer to prevention of cow's milk allergy?
I think it was sounding in between what I was saying. I'm a strong believer in that, also in prevention. And to be honest, the prevention idea was born 100 years ago with the first Nobel Prize, or one of the first Nobel Prize in medicine for Mechtinghoff, which the observing that shepherds are living longer when they consume live bacteria in the form of a yogurt or a kefir or whatever. The question is actually, I think, a little bit more complicated in nowadays. Do we have enough proof that certain formulations, certain probiotic strains, and especially certain prebiotic strains have enough evidence for in terms of allergy prevention or in terms of dietary management of allergy? Yes, we have evidence. Yeah, yes, it is sometimes very weak, sometimes very low, sometimes also not convincing, because the topic is not easy to assess. You cannot anymore easy set up randomized controlled trials where you can exclude breastfeeding as an example. Breastfeeding is the best nutrition for the infant and has always to be supported. So an additional effect of a certain prebiotic or probiotic is very hard to show. And breast milk has definitely the best prebiotics and the best probiotics. It is a fantastic magic formulation which we are not, which we are far away to have equality or similar composition and effects. So a long way to go. But yes, I think if breastfeeding is not possible, then it would be not wise not to try to come to those effects as close as possible.
And Professor Salmonen, what do you think on that question? Have we found the answer, the cure?
Well, we haven't found the answer for cure, but we are getting closer all the time. And we have quite a few allergy prevention studies among our own studies from Finland, and they are quite promising in terms of efficacy. But again, as Udo said, it's very important that breastfeeding is still better. It's a better choice, and quite often the breastfeeding overcomes the effect of probiotics or prebiotics. So if if you have a choice, then the choice is breastfeeding.
Breast milk. And now coming back to the second part, because you know, whilst you guys are talking, I see more questions on this topic. So Professor Hertz, in terms of, let's say, symbiotics, in regards to a child that's not breastfed, that's on a hypoallergenic formula, do you think symbiotics actually promotes tolerance so that you outgrow your cow's milk allergy faster?
Yeah, the data look like that, at least from the most recent studies. There seems to be a timing effect. So we could maybe say faster. You shorten the actually resolution time. The question, the critical question is there, what is the definition of tolerance? What is outgrowing cow's milk allergy? Yep. I personally don't believe it is just simply an outgrowing. That is a clinical tolerance. It is the absence of a clinical symptomatic. Most of the time, unfortunately, we see multiple food sensitization. We see replacement of cow's milk allergy by other allergens, aeroallergens, dust, mite, pollen, grass, or whatever. So there is no real acquisition of oral tolerance. I'm a strong believer in this, what I said at the beginning of my presentation. Once you have learned something to recognize as harmful, it is very different to turn that back. So the most important is you learn it right at the beginning as harmless. And that is the real true prevention. We are all have oral tolerance developed amongst many things. It is not normal to have an overreaction of the immune system, but once we have an overreaction, it is very difficult to redirect, and we know that all from our own experience. If you look into where we have this beneficial effect is, we use the same principle in vaccination. We combine a vaccine with a danger signal, and once we have been vaccinated against pox, yeah, we have it for decades. We don't lose it. So this memory function is the key for oral tolerance.
Yeah. I'm going to move on with another question because we've got 2 minutes left. So for Professor Salminen, and I think this positive message of breastfeeding is really important, but then we've had lots of questions coming through saying, is it worth supplementing either the mother who's breastfeeding in regards to probiotics, you know, does that make an effect, or is it better just supplementing the baby with the probiotics? What do you think?
Well, I think the nutritional approach is very, very important here. So supplementing the mother would be also important during breastfeeding, maybe even before breastfeeding, because the mother is at least partly responsible for the microbiota that's transferred to the infant before birth and at delivery and during breastfeeding. But if that's not possible, then the other option is to supplement the food for the infant.
Yeah. And I think that's such a good final message to kind of get out to say we still agree that breast milk is most probably is our gold standard, what we are trying to achieve. So I'm going to say thank you to both of you. I think it was an amazing session. I just wanted to say that whilst we've been talking, we had another 30 questions. And I just want to say for those of you who are dialing in, I'm sorry that we did not answer these questions live, but want to reassure you, we will be answering them in some digital format. I want to say to both speakers, thank you very much. And both speakers have a wonderful evening. I'm going to now move to wrapping up the session and going to say bye to both of you.
Thank you.
Thank you.